Nice. So let's start. Okay, we are live. Hide comments, hide everything. So we are live again. Slazy, is it public? Okay. Now I am going to do questions. Slazy, I have a pro, and I am going to answer these questions and answer. So, a 62-year-old heavy smoker presented with worsening dyspnea. A 62 years old heavy smoker presented with pulmonary function tests reveal an FEV1 FVC ratio of this 0.56, which means ከኖርማሉ በጣም ያነሰ ነው። Wait a minute. ከኖርማሉ በጣም ያነሰ ነው. And which of the following sets of lung volume change is most characteristics of this patient's condition? So FVF forced expiration volume 1 ማለት ነው አንድ ጊዜ ፑ ስናደርግ ማለት ነው it is very small. So if it is very small, obstructive disease እንደሆነ ግልጽ ነው. For obstructive disease there will be what? Decrease TLC and increase RV. So there will be RV increase እንደሚያደርግ ግልጽ ነው because ውስጥ more storage reserve volume ስላለ so increase የሚለውን እናያለን. So is it increase? I say C is the answer. So in obstructive disease, COPD, air trapping leads to hyperinflation, which characteristically increases both total lung and residual capacity. And yes, we were right ማለት ነው. So in the pathogenesis of emphysema, what is the primary mechanism by which cigarette smoke leads to destruction of alveolar walls? So emphysema ላይ alveolar walls destruction ይሆናሉ. So what is the direct way? The first one is activation of complement cascade. Okay, then induction of type 2 pneumocyte hyperplasia. ሶስተኛ recruitment of neutrophils and elastase, and አራተኛ direct inhibition of surfactant. I believe this is the answer. So yes, smoke recruits neutrophils that release elastase. With this exceeds the inhibitory capacity of alpha-1 antitrypsin. It results in the degradation of elastic tissue. ሶስተኛ in pathology report for lung biopsy mentions RAID index 0.5. What is RAID index? I don't know what a RAID index is. So pathology report for lung biopsy mentions a RAID index of this, the biopsy. So the pathology RAID index. Which of the following morphologic change is most likely associated with this finding? So the morphologic change that is associated with this passage of air through the pores of cone, destruction of distal alveolar septa, passive expansion of the remaining lung, hypertrophy of submucosal glands. I have no clue about this, so what should I do? Let us ask the AI. So Google, Gemini. Let me ask Gemini itself. So, hey Gemini, I am doing questions, but I found a new topic. Questions. What should I do? Topics which I haven't covered. Should I stop reading and stop doing questions and read, or continue doing the questions? Okay. Defining dilemma. Optimizing. Okay. Now let's return. So ይህን ሬድ ኢንዴክስ አላውቅም። So report አለ which more of the following morphological change is most likely associated with this finding? Passage of air. Okay, so it is common in road, especially when it dense heavy. Okay, so if the new topic only makes up a few scattered questions, keep going, use them. Yes, when to stop, read if you hit a block question where you don't even recognize core vocabulary like entire respiratory, binding quest, guessing, waste time if you don't know the basic definition of. Okay, to target the scheme, don't read the entire chapter. Okay, ስለዚህ አሁን ሬድ ኢንዴክስ አላውቀውም። ስለዚህ ሌታስ ዱ ዳት እንዳለኝ ማለት ነው። ቢካዝ ዋት ሬድ ኢንዴክስ አላውቀውም። ሬድ እሺ what is this? Okay, chronic bronchitis ነው። Okay, now let's be fast and read this very fast. So AI እዚህ ጋር አለኝ
502 CHAPTER13. Clinical features. The course of chronic bronchitis is quite variable. In some patients, cough and sputum production persist indefinitely without ventilatory dysfunction, while others develop COPD with significant outflow obstruction marked by hypercapnia, hypoxemia, and cyanosis. Patients with chronic bronchitis and COPD have frequent exacerbations, more rapid disease progression, and poorer outcomes than those with emphysema alone. Progressive disease is marked by the development of pulmonary hypertension, sometimes leading to cardiac failure, Chapter 11, recurrent infections, and ultimately respiratory failure. Chronic bronchitis. Chronic bronchitis is diagnosed on clinical grounds. It is defined by the presence of a persistent productive cough for at least 3 consecutive months in at least 2 consecutive years. It is common among cigarette smokers and urban dwellers in smog-ridden cities. Some studies indicate that 20% to 25% of men in the 40 to 65-year-old age group have the disease. In early stages of the disease, the cough raises mucoid sputum, but airflow is not obstructed. Some patients with chronic bronchitis have evidence of hyperresponsive airways, with intermittent bronchospasm and wheezing, asthmatic bronchitis, while other bronchitic patients, especially heavy smokers, develop chronic outflow obstruction, usually with associated emphysema, COPD. Pathogenesis. The distinctive feature of chronic bronchitis is hypersecretion of mucus, beginning in the large airways. Although the most important cause is cigarette smoking, other air pollutants, such as sulfur dioxide and nitrogen dioxide, may contribute. These environmental irritants induce hypertrophy of mucus glands in the trachea and bronchi as well as an increase in mucin-secreting goblet cells in the epithelial surfaces of smaller bronchi and bronchiales. These irritants also cause inflammation marked by the infiltration of macrophages, neutrophils, and lymphocytes. In contrast with asthma, eosinophils are not seen in chronic bronchitis. Whereas the defining mucus hypersecretion is primarily a reflection of involvement of large bronchi, the airflow obstruction in chronic bronchitis results from 1. Small airway disease, induced by mucus plugging of the bronchiolar lumen, inflammation, and bronchiolar wall fibrosis, and 2. Coexistent emphysema. In general, while small airway disease, chronic bronchiolitis, is an important component of early, mild airflow obstruction, chronic bronchitis with significant airflow obstruction almost always is complicated by emphysema. It is postulated that many of the effects of environmental irritants on respiratory epithelium are mediated by local release of cytokines such as IL-13 from T cells and innate lymphoid cells. The transcription of the mucin gene in bronchial epithelium and the production of neutrophil elastis are increased as a consequence of exposure to tobacco smoke. Microbial infection often is present but has a secondary role, chiefly by maintaining inflammation and exacerbating symptoms. Summary. Chronic bronchitis. Chronic bronchitis is defined as persistent productive cough for at least 3 consecutive months in at least 2 consecutive years. Cigarette smoking is the most important underlying risk factor. Air pollutants also contribute. Chronic airway obstruction largely results from small airway disease, chronic bronchiolitis, and coexistent emphysema. Histologic examination demonstrates enlargement of mucus secreting glands, goblet cell metaplasia, and bronchiolar wall fibrosis. Morphology. As seen in gross specimens, the mucosal lining of the larger airways usually is hyperemic and swollen by edema fluid and is covered by a layer of mucinous or mucopurulent secretions. The smaller bronchi and bronchioles also may be filled with secretions. The diagnostic feature of chronic bronchitis in the trachea and larger bronchi is enlargement of mucus-secreting glands, Fig 13.9. The magnitude of the increase in size is assessed by the ratio of the thickness of the submucosal gland layer to that of the bronchial wall, the read index normally 0.4. Variable numbers of inflammatory cells, largely. Fig 13.9 Chronic bronchitis. The lumen of the bronchus is above. Note the marked thickening of the mucus gland layer, approximately twice normal, and squamous metaplasia of lung epithelium. From the teaching collection of the Department of Pathology, University of Texas, Southwestern Medical School, Dallas, Texas. Lymphocytes and macrophages but sometimes also admixed neutrophils, are frequently seen in the bronchial mucosa. Chronic bronchiolitis, small airway disease, characterized by goblet cell metaplasia, mucus plugging, inflammation, and fibrosis, also is seen. In severe cases, there may be complete obliteration of the lumen as a consequence of fibrosis, bronchiolitis obliterans. It is the submucosal fibrosis that leads to luminal narrowing and airway obstruction. Emphysema 2 changes often coexist. http://ebooksmedicine.net. Obstructive lung. Asthma. Asthma is a chronic inflammatory disorder of the air.
So rates, okay, rate index variable. Okay. I hope. እሺ ስለዚህ ምንድን ነው አሁን ቅድም ባለበት በጣም እየወረደ ነው። Cool guys. Let's go. ብርዱን አልቻልኩትም። ከሌሊቱ 9 ሰዓት 8 ሰዓት ነው አልተኛውም። ብዙ ማስገባው አሳይመንት ነበረ፣ እሱን ጨራርሼ ነው ያለሁት። ሶ ሌትስ ሪድ። ዛሬ አልተኛም። Okay, pathology report for lung biopsy mentions a rate index. Which of the following morphological changes most likely associated with this finding? Hypertrophy of submucosal gland አይደለም አሁን ባየነው መሰረት ዲቴል ግን አላየሁም። Yes sir. Yes sir. So rate index measure the ratio of thickness of submucosal gland layer to the total bronchial wall thickness. A value indicates hypertrophy characteristic of chronic bronchitis. Yes sir. So which anatomic type of emphysema is most strongly associated with congenital deficiency in the protease? This protease inhibitor alpha 1 antityrosine. Irregular emphysema, centrosinar emphysema, panasinar emphysema, and paraseptal emphysema. Alag. It is emphysema እንደሆነ አውቃለሁ, but what their difference? No idea. ስለዚህ ይሄን ሄደን እንየው ማለት ነው። Because what is the rule? The winning strategy question driven reading. Instead of choosing strictly between reading and testing, combine them to keep your study. Read the question first. Even if you haven't covered the topic, look at exactly what is being asked. Identify the topic gap and are they asking about it? Okay, hunt for the question, open your text and this. So let's when to stop read. Do a target scheme. Okay, ስለዚህ alright. ስለዚህ አሁን ይሄን አላውቀውም። ኢሬጉላር ነው፣ ሴንትራሲናር፣ ፓናሲናር ኦር ፓራሴፕታል የቱ እንደሆነ አላውቅም። ስለዚህ እንሄድና ኢምፔሲማ እናነባለን ማለት ነው። ዝም ብዬ ከመቀላወጥ ይሄን ነገር ይችላል። ሶ ሌትስ ሲ። ሶ እዚህ ጋር መጥቶልሃል ማለት ኢምፔሲማ obstructive restrictive diseases are obstructive airway. So emphysema is characterized by permanent enlargement of air sacs air spaces distal to terminal bronchioles accompanied by destruction of their wall without significant fibrosis. So it is classified according to its distribution as discussed earlier. The sinus is the structure distal to terminal. By destruction of their walls without significant fibrosis, it is classified according to its anatomic distribution. As discussed earlier, the sinus is the structure distal to terminal bronchioles and the cluster to the 2, 3 to 5 axa sinus called lobules. There are 4 major types of emphysema: acinar, pana-acinar, distal acinar, and irregular. Only the first 2 types cause significant airway obstruction, with central acinar emphysema being about 20 times more common than pana-acinar disease. Centra-acinar centrilobular emphysema. The distinctive feature of centra-acinar emphysema is that the central or proximal part of a sign formed by respiratory bronchioles are affected while distal alveoli are spared.
Ways that causes recurrent episodes of wheezing, breathlessness, chest tightness, and cough. Obstructed lung, airway, diseases 499. Bronchioles are affected, while distal alveoli are spared. Thus, both emphysema 2 and normal air spaces exist within the same acinus and lobule. See Fig 13.5b. The lesions are more common and severe in the upper lobes, particularly in the apical segments. In severe centriacinar emphysema, the distal acinus also becomes involved, and thus, the differentiation from panacinar emphysema becomes difficult. This type of emphysema is most common in cigarette smokers, often in association with chronic bronchitis. Panacinar, panlobular, emphysema. In panacinar, panlobular, emphysema, the acini are uniformly enlarged, from the level of the respiratory bronchiole to the terminal blind alveoli. See Fig 13.5c. In contrast to centriacinar emphysema, panacinar emphysema occurs more commonly in the lower lung zones and is associated with alpha-1 antitrypsin deficiency. Distal acinar, paraseptal, emphysema. In this form of emphysema, the proximal portion of the acinus is normal but the distal part is primarily involved. The emphysema is more striking adjacent to the pleura, along the lobular connective tissue septa, and at the Table 13.1 disorders associated with airflow obstruction, the spectrum of chronic obstructive pulmonary disease. Clinical entity. Anatomic. Cite major pathologic changes, etiology, signs/symptoms. Chronic bronchitis, bronchus, mucus gland hypertrophy and hyperplasia, hypersecretion. Tobacco smoke, air pollutants, cough, sputum production. Bronchiectasis, bronchus, airway dilation and scarring, persistent or severe infections, cough, purulent sputum, fever, asthma, bronchus, smooth muscle hypertrophy and hyperplasia, excessive mucus, inflammation. Immunologic or undefined. Causes. Episodic wheezing, cough. Dyspnea. Emphysema, acinus, airspace enlargement, wall. Destruction. Tobacco smoke, dyspnea. Small airway disease. Bronchiolitis asterisk. Bronchiole inflammatory scarring, partial obliteration of bronchioles. Tobacco smoke, air pollutants, cough, dyspnea. Asterisk can be present in all forms of obstructive lung disease or by itself. Margins of the lobules. It occurs adjacent to areas of fibrosis, scarring, or atelectasis and is usually more severe in the upper half of the lungs. The characteristic finding is the presence of multiple, contiguous, enlarged air spaces ranging in diameter from less than 0.5 mm to more than 2.0 cm, sometimes forming cystic structures that, with progressive enlargement, give rise to bullae. The cause of this type of emphysema is unknown. It comes to attention most often in young adults who present with spontaneous pneumothorax. Fig 13.4 schematic representation of overlap between chronic obstructive lung diseases. Small airway disease. Emphysema. Alveolar wall destruction, overinflation. Chronic bronchitis, productive cough. Airway inflammation. Asthma. Reversible obstruction. Bronchial hyperresponsiveness triggered by allergens, infection, etc. Chronic injury, example smoking. Fig 13.5 major patterns of emphysema. A. Diagram of normal structure of the acinus, the fundamental unit of the lung. B. Centriacinar emphysema with dilation at 500 CHAPTER 13 lung. To develop pulmonary emphysema, which is compounded by smoking. About 1% of all patients with emphysema have this defect. Alpha-1 antitrypsin, normally present in serum, tissue fluids, and macrophages, is a major inhibitor of proteases, particularly elastase, secreted by neutrophils during inflammation. Alpha-1 antitrypsin is encoded by a gene in the proteinase inhibitor, pi, locus on chromosome 14. The pi locus is polymorphic, and approximately 0.012% of the U.S. population is homozygous for the Z allele, a genotype that is associated with markedly decreased serum levels of alpha-1 antitrypsin. More than 80% of these individuals develop symptomatic panacinar emphysema, which occurs at an earlier age and is of greater severity if the individual smokes. Protease-mediated damage of extracellular matrix has a central role in the airway obstruction seen in emphysema. Small airways are normally held open by the elastic recoil of the lung parenchyma, and the loss of elastic tissue in the walls of alveoli that surround respiratory bronchioles reduces radial traction and thus causes the respiratory bronchioles to collapse during expiration. This leads to functional airflow obstruction despite the absence of mechanical obstruction. Irregular emphysema. Irregular emphysema, so named because the acinus is irregularly involved, is almost invariably associated with scarring, such as that resulting from healed inflammatory diseases. Although clinically asymptomatic, this may be the most common form of emphysema. Pathogenesis. Inhaled cigarette smoke and other noxious particles cause lung damage and inflammation, which, particularly in patients with a genetic predisposition, result in parenchymal destruction, emphysema, and airway disease, bronchiolitis and chronic bronchitis. Factors that influence the development of emphysema include the following. Fig 13.6. Inflammatory cells and mediators, a wide variety of inflammatory mediators have been shown to be increased, including leukotriene B4, IL-8, TNF, and others, that attract more inflammatory cells from the circulation. Chemotactic factors, amplify the inflammatory process, pro-inflammatory cytokines, and induce structural changes, growth factors. The inflammatory cells present in lesions include neutrophils, macrophages, and CD4+ and CD8+ T cells. It is not known if the T cells are specific for a particular antigen or are recruited as part of inflammation. Protease, anti-protease imbalance, several proteases are released from the inflammatory cells and epithelial cells that break down connective tissues. In patients who develop emphysema, there is a relative deficiency of protective anti-proteases, further discussed below. Oxidative stress, reactive oxygen species are generated by cigarette smoke and other inhaled particles and released from activated inflammatory cells such as macrophages and neutrophils. These cause additional tissue damage and inflammation. Chapter 3. Airway infection. Although infection is not thought to play a role in the initiation of tissue destruction, bacterial and/or viral infections cause acute exacerbations. The idea that proteases are important is based in part on the observation that patients with a genetic deficiency of the antiprotease alpha-1 antitrypsin have a predisposition. Fig 13.6 Pathogenesis of emphysema. See text for details. Smoking or air pollutant. Plus. Genetic predisposition. Alveolar wall destruction. Protease, antiprotease imbalance. Congenital 1 antitrypsin deficiency. Inflammatory. Cells, release of inflammatory mediators. Oxidative stress, increased. Apoptosis and senescence. Morphology. The diagnosis and classification of emphysema depend largely on the macroscopic appearance of the lung. Typical Pannicener emphysema produces pale, voluminous lungs that often obscure the heart when the anterior chest wall is removed at autopsy. The macroscopic features of Centriocener emphysema are less impressive. Until late stages, the lungs are a deeper pink than in Pannicener emphysema and less voluminous, and the upper two-thirds of the lungs are more severely affected than the lower lungs. Histologic examination reveals destruction of alveolar walls without fibrosis, leading to enlarged air spaces. Fig. 13.7. In addition to alveolar loss, the number of alveolar capillaries is diminished. Terminal and respiratory bronchiales may be deformed because of the loss of septa that help. Fig. 13.7 Pulmonary emphysema. There is marked enlargement of the air spaces, with destruction of alveolar septa but without fibrosis. Note the presence of black anthracotic pigment. http://ebooksmedicine.net. Clinical features. Dyspnea usually is the first symptom. It begins insidiously but is steadily progressive. In patients with underlying chronic bronchitis or chronic asthmatic bronchitis, cough and wheezing may be the initial complaints. Weight loss is common and may be severe enough to suggest an occult malignant tumor. Pulmonary function tests reveal reduced FEV1 with normal or near normal FVC. Hence, the FEV1 to FVC ratio is reduced. The classic presentation of emphysema with no bronchitic component is one in which the patient is barrel-chested and dyspneic, with obviously prolonged expiration, sitting forward in a hunched-over position. In these patients, air space enlargement is severe and diffusing capacity is low. Dyspnea and hyperventilation are prominent, so that until very late in the disease, gas exchange is adequate and blood gas values are relatively normal. Because of prominent dyspnea and adequate oxygenation of hemoglobin, these patients sometimes are called pink puffers. At the other end of the clinical spectrum is a patient with emphysema who also has pronounced chronic bronchitis and a history of recurrent infections. Dyspnea usually is less prominent, and in the absence of increased respiratory drive the patient retains carbon dioxide, becoming hypoxic and often cyanotic. For unclear reasons, such patients tend to be obese, hence the designation blue bloaters. In most patients with COPD the symptoms fall in between these two extremes. Hypoxia-induced pulmonary vascular spasm and loss of pulmonary capillary surface area from alveolar destruction causes the gradual development of secondary pulmonary hypertension, which in 20% to 30% of patients leads to right-sided congestive heart failure, COR pulmonale, Chapter 11. Death from emphysema is related to either respiratory failure or right-sided heart failure. Conditions related to emphysema. Several conditions involving abnormal air spaces or accumulations of air within the lungs or other tissues also are recognized. Compensatory emphysema describes the dilation of resid. UAL alveoli in response to loss of lung substance elsewhere, such as occurs after surgical removal of a diseased lung or lobe. Obstructive overinflation refers to expansion of the lung due to air trapping. A common cause is subtotal obstruction of an airway by a tumor or foreign object. Obstructive overinflation can be life-threatening if expansion of the affected portion produces compression of the remaining normal lung. Bullous emphysema refers to any form of emphysema that produces large subpleural blebs or bullae, spaces greater than 1 cm in diameter in the distended state, Fig. 13.8. Such blebs represent localized accentuations of one of the four forms of emphysema. Most often the blebs are subpleural, and on occasion they may rupture, leading to pneumothorax. Mediastinal, interstitial, emphysema is caused by entry of air into the interstitium of the lung, from where it may track to the mediastinum and sometimes the subcutaneous tissue. It may occur spontaneously if a sudden increase in intraalveolar pressure, as with vomiting or violent coughing, produces alveolar rupture, which allows air to dissect into the interstitium. Sometimes it develops in children with whooping cough. It may also occur in patients on respirators who have partial bronchiolar obstruction or in individuals with a perforating injury, example a fractured rib. When the interstitial air gets into the subcutaneous tissue, the patient may literally blow up like a balloon, with marked swelling of the head and neck and crackling crepitation over the chest, subcutaneous emphysema. In most instances the air is resorbed spontaneously after the site of entry seals. Summary. Emphysema. Emphysema is a chronic obstructive airway disease characterized by enlargement of air spaces distal to terminal bronchioles. Subtypes include Centriocener, most common, smoking-related, Pannicener, seen in alpha-1 antitrypsin deficiency, Distillacener, and irregular. Smoking and inhaled pollutants cause ongoing accumulation of inflammatory cells, which are the source of proteases such as elastases that irreversibly damage alveolar walls. Patients with uncomplicated emphysema present with increased chest volumes, dyspnea, and relatively normal blood oxygenation at rest, pink puffers. Most patients with emphysema also have signs and symptoms of concurrent chronic bronchitis, since cigarette smoking is a risk factor for both. Tether these structures in the parenchyma. With the loss of elastic tissue in the surrounding alveolar septa, radial traction on the small airways is reduced. As a result, they tend to collapse during expiration, an important cause of chronic airflow obstruction in severe emphysema. Bronchiolar inflammation and submucosal fibrosis are consistently present in advanced disease. Fig. 13.8 Bullous emphysema with large apical and subpleural bullae. From the teaching collection of the Department of Pathology, University of Texas Southwestern Medical School, Dallas, Texas. http://ebooksmedicine.net. 502 CHAPTER 13 lung. Clinical features. The course of
ماشي. علاقم blue bladder. ኦኬ ደልቼዋለሁ ሁሉንም። Yes sir. What the hell? Blue blotters emphysema ላይ ነው እንዳለው። Just join. I'm hyperinflation ነው።
Hi everyone, and welcome to our module on COPD diagnosis. COPD stands for chronic obstructive pulmonary disease, and COPD is a very common chronic lung disorder. It causes dyspnea and cough, and it's progressive and can lead to death. The clinical features and symptoms of COPD fall under several subtypes. The two most important ones are chronic bronchitis and emphysema, and we'll talk about both of these in this video. The third subtype is asthma COPD. These are essentially patients with severe asthma that has progressed so that it is no longer a reversible lung condition and is now chronic. These people have basically progressed from asthma to COPD. This is relatively uncommon, and I won't talk about this subtype very much in this video. In patients with the chronic bronchitis subtype of COPD, the major problem is inflammation of the airways. If you look at this drawing on the screen here, on the left is the airway of a healthy patient, and on the right is what the airway looks like in a patient with chronic bronchitis. As you can see, the airway is inflamed, there's excess mucus, and the airway is narrowed, allowing less airflow. In terms of symptoms, this leads to a chronic cough and production of sputum. And to meet criteria for the chronic bronchitis subtype of COPD, symptoms of chronic cough productive of sputum have to be present for at least 3 months a year over 2 consecutive years, and there has to be no other cause of cough present. In the emphysema subtype of COPD, the major problem is destruction of the alveolar walls. If you look at this drawing at the bottom of the screen, on the left is a healthy alveoli. On the right are the alveoli of a patient who has emphysema. And you can see that the walls have essentially broken down. This is the major problem in patients with the emphysema subtype of COPD. This is caused by inflammatory cells that release proteases, which break down proteins, especially they break down elastin, which causes the elastic recoil of the alveoli to be lost. This is an important piece of the pathophysiology of the emphysema subtype. Because of this, the small airways collapse on exhalation and air gets trapped into the lung. So people with the emphysema subtype of COPD have dyspnea because their alveoli don't work. They hyperventilate to try and get more oxygen into their body with the remaining alveoli that function. And they can have some cough, but it's less than that of chronic bronchitis. So going back to this slide, what I just described for you is the classic picture of pure chronic bronchitis or pure emphysema, but you should know that many patients have elements of both subtypes, and that's why we call their disorder COPD and not chronic bronchitis or emphysema. The major risk factor for COPD is cigarette smoking. The vast majority of patients with COPD are either current or former smokers. Rarely, there are other associations that lead to COPD. Some patients with a history of environmental exposures develop chronic obstructive pulmonary disease. And later in this video, we'll talk about alpha-1 antitrypsin deficiency, which is an inherited condition that can lead to COPD in non-smokers. COPD is a chronic condition with intermittent exacerbations, so patients with COPD will have some baseline level of pulmonary functioning that may not be normal, but then they will intermittently get worse and then recover from that exacerbation. That's the typical course. And almost all patients have some element of dyspnea and cough. As we talked about before, cough is more prevalent with the chronic bronchitis subtype, but dyspnea and cough are basically typical symptoms of all forms of COPD to some degree. Now, like I said before, most patients with COPD have some elements of chronic bronchitis and emphysema. However, the different underlying problems cause different symptoms. So chronic bronchitis leads to a prolonged expiratory phase. If you listen to the lungs of a patient with chronic bronchitis, they will exhale slowly. It will take a long time for them to get the air out, and that's because their airways are narrowed from inflammation and thickening. Bronchi and wheezing are also features that tend to occur in patients with chronic bronchitis because of the narrowing of the airways. Emphysema tends to lead to decreased breath sounds, so because the alveolar walls have been destroyed, you hear less air movement in the lungs. Emphysema leads to air trapping, so the patient's chest can take on a barrel chest appearance. Shown on the screen here is a normal person and a person with a barrel chest next to him. And then finally, some patients with COPD breathe through pursed lips. And by pursing the lips, this causes the pressure in the airways to rise, and this keeps them from collapsing. So pursed-lipped breathing is a classic feature of patients with emphysema and COPD. So you can basically think of COPD as a spectrum with chronic bronchitis on one end and emphysema on the other. And most patients exist somewhere along this spectrum, usually with some features of both subtypes. But in its pure form, a patient with isolated chronic bronchitis is classically described as a blue bloater. The reason this description is applied to patients with pure chronic bronchitis is because these patients are often blue and cyanotic, and that's because they have marked hypoxemia from shunting. So when air cannot get into the alveoli because the bronchioles are inflamed, you have blood flowing past airways not being ventilated. This is called developing shunting, and this will lead to hypoxemia. The hypoxemia causes pulmonary vasoconstriction. This causes pulmonary hypertension, and then these patients eventually develop edema from right heart failure. So for all these reasons, they're described as a blue bloater. In contrast, the patient with pure isolated emphysema is classically described as a pink puffer. For this patient, the major problem is loss of alveoli, and with the loss of alveoli, there's loss of surface area for oxygen absorption. This means that parts of the lung are going to be ventilated, but no gas exchange will occur. And anytime you have parts of the lung that are ventilated without gas exchange, that's called the presence of dead space. So what these patients are going to do is hyperventilate to compensate. They're going to try to ventilate the working alveoli to make up for the dead space where no gas exchange occurs. And for this reason, they will usually be breathing rapidly, and they're called a puffer. Also, the hyperventilation initially maintains their oxygen level so they don't turn cyanotic like the blue bloater, and therefore they're described as a pink puffer. And these are really sort of ends of the spectrum, as I said before. Most patients are somewhere in the middle, with elements of both chronic bronchitis and emphysema. If you think a patient has COPD, the best initial test is a chest X-ray. And the classic findings on chest X-ray in patients with COPD are hyperinflation of the lungs, flattened diaphragms, and an increased AP diameter. If you look at these two X-rays on the screen, on the left side, this is a normal patient. On the right side is a patient with COPD. And hopefully you can appreciate that the lung fields are just much, much bigger in this patient with COPD. That's evidence of hyperinflation. Also, if you look at the diaphragms on the normal patient, you can see they're curved. They come all the way down the side like this. In the patient with COPD, they're much more flat, and that's the flattening of the diaphragm in patients with COPD. And here are two lateral X-rays. On the left is a normal patient, and you can see that the anterior-posterior diameter of the chest is relatively narrow compared to the patient with COPD on the right. The patient on the right has a barrel chest and an increased AP diameter, a classic X-ray finding in COPD. In another video, I talk about pulmonary function testing in general, but here I'll just briefly review the pulmonary function testing findings you would expect in a patient with COPD. So COPD has the classic findings of obstructive lung disease on pulmonary function testing. So this includes a reduction in the FEV1 due to slow flow of air out of the lungs, and a reduction in the forced vital capacity because less air is able to be pushed out with each breath. The other classic finding in obstructive lung disease is a reduction in the FEV1 to FVC ratio, and this ratio must be reduced to be less than 70% to meet criteria for COPD. A reduction in the FEV1 to FVC ratio is the hallmark of obstructive lung diseases like COPD. In addition, there must be partial or no change in the FEV1 with bronchodilators. So when you administer bronchodilators, if the FEV1 improves, then that suggests that the obstruction is reversible, and that means that you have a patient with asthma. In patients who have COPD, the change is chronic and not reversible, so there should be little or no change in the FEV1, and this distinguishes COPD from patients who have asthma. So both of these findings here, which are bolded, are mandatory to make a diagnosis of COPD. Make sure you know this. They're going to want you to know it for your boards. So I told you on the last slide that patients with COPD have a reduced forced vital capacity. That's because they're less able to get air out of their lungs compared to normal. But you should know that this is the only important lung volume or capacity that's reduced in COPD. All the other lung volumes are increased, and that's because these patients have air trapping. So their total lung capacity is increased, their functional residual capacity is increased, and their residual volume is also increased. And these volumes and capacities I talk about in more detail in the video on pulmonary function testing. Shown on this slide are a series of flow volume loops for patients with normal lungs and various lung disorders. On the far left side is a flow volume loop for a patient with normal lungs. When patients develop obstruction like COPD, what happens is that the flow volume loop develops this scooped out appearance right here. And the worse the obstruction, the more the indentation of the scooped portion of the flow volume loop. And I talk about flow volume loops in more detail in the video on pulmonary function testing. Another test that can be useful in the workup of patients who may have COPD is measurement of the DLCO, which is the diffusing capacity of carbon monoxide. This test measures the abilities of the lungs to transfer gas from the air into the bloodstream. The way this test works is the patient inhales a small amount of carbon monoxide. You may know that carbon monoxide is dangerous, but this small amount is relatively safe. Then the machine measures the amount of carbon monoxide exhaled, and the more that is absorbed into the bloodstream by the lungs, the less that will be exhaled. Based on the amount that is exhaled, the computer calculates a diffusing capacity for carbon monoxide, and then based on patient factors, it compares the patient's DLCO to a predicted value. So a normal result is anywhere from 75 to 140% of the predicted value. Patients who have severe forms of lung disease can have a result for DLCO that's less than 40%. And the DLCO is decreased in many forms of restrictive lung disease like pulmonary fibrosis, which I talk about in another video. But in terms of COPD, the DLCO is decreased among patients with emphysema, but not patients with chronic bronchitis. And as I told you before, many patients have a mixture of both of these, so therefore many patients with COPD have a reduced DLCO. On your board exams, they will almost certainly ask you to know the expected arterial blood gas results in a patient with long-standing COPD, so let's talk about that now. So patients with significant COPD are hypoxemic even at rest and often need oxygen, so the blood gas will show a decreased PaO2. These patients chronically retain carbon dioxide, and you have to remember this to understand the blood gas results that you will get in all patients with COPD. So their PaCO2 is always high, and for this reason they have a chronic respiratory acidosis, because anytime your CO2 is high, that produces acid. As a physiologic response to the acidosis, the kidneys produce more bicarbonate, so COPD patients always have a high bicarbonate. This is a form of metabolic alkalosis that is a physiologic adaptation and response to the chronic respiratory acidosis. And then finally, the arterial pH is usually slightly reduced or low normal. The respiratory acidosis reduces the pH. The metabolic alkalosis raises the pH. In most cases, the pH does not come all the way back to normal, but in some cases, the kidneys are able to generate enough bicarbonate that the pH will be in the low normal range. So I've summarized these results on the bottom of the screen. The normal PaO2 is about 90 and it's reduced in COPD. The normal PaCO2 is about 40 and it's increased in COPD. A normal bicarbonate is 24 and it's increased in COPD. And finally, a normal pH is 7.4 and it's either decreased or at the low end of normal in patients with COPD. Since the FEV1 falls in patients with COPD, we determine their disease severity based on their FEV1. Patients with class 1 COPD have mild disease, and they have an FEV1 that's greater than or equal to 80% of predicted. Moderate COPD is 50 to 79%, and severe is 30 to 49%. And then finally, patients with very severe COPD have an FEV1 that's less than 30% of predicted. Let's talk about how to differentiate COPD versus CHF. Both of these conditions cause dyspnea, and they can both occur in patients who are smokers. Let's start by talking about symptoms. Patients with heart failure can have orthopnea and PND from left heart failure, and you will never see these symptoms in patients with COPD. Patients with heart failure can have cough, so you should be aware that just because a patient is coughing, that does not mean they necessarily have COPD. On lung exam, the classic findings in heart failure are rales at the bases or bibasilar rales. There can be decreased breath sounds at the bases from effusions. And sometimes people with heart failure will wheeze. This is called cardiac wheezing. So just like with coughing, if a patient is wheezing, that doesn't necessarily mean they don't have heart failure. In COPD, patients classically have diffuse wheezing, and then rhonchi is a symptom that's usually only seen in people with COPD. The jugular venous pressure is increased in patients with heart failure, and it can be increased in patients with COPD. If patients with COPD have developed right heart failure and cor pulmonale, then they can have an increased JVP. On the other hand, if they haven't developed right heart failure from their lung disease, then they should have a normal JVP. Measurement of the serum BNP can be helpful in differentiating heart failure from COPD. That's the main use of BNP, is to distinguish heart failure from other conditions. The BNP level is increased in heart failure. It's normal in COPD. The chest x-ray in heart failure shows pulmonary edema, and in COPD it shows those findings we saw earlier in this video, things like hyperinflation and flattening of the diaphragm. If you do an arterial blood gas in patients with heart failure and COPD, both groups of patients can have hypoxemia. What's different is the carbon dioxide level. Patients with COPD retain carbon dioxide from chronic lung disease, so they will have a high CO2 and a high bicarbonate like we talked about earlier. Patients with chronic heart failure do not retain CO2, and in the midst of a heart failure exacerbation, they are usually hyperventilating, so they should have a low CO2. And then finally, if you do a right heart catheterization and you measure the pulmonary capillary wedge pressure, this is a surrogate for left atrial pressure. It will be high in patients with heart failure. It's normal in patients with COPD. I'll finish this video by talking about alpha-1 antitrypsin deficiency, which is a rare disorder that can lead to emphysema and COPD. Alpha-1 antitrypsin deficiency is an inherited disorder. It's transmitted in an autosomal co-dominant manner. What I mean by codominant is that there are two alleles that can be involved in this disorder. The normal allele is the M allele, and the abnormal allele is the Z allele. So patients who don't have alpha-1 antitrypsin deficiency have two copies of the normal allele. They are MM. Patients with alpha-1 antitrypsin deficiency can be either MZ or ZZ. The MZ patients have one normal allele, so they have a milder form of the disease. The ZZ patients have no normal alleles, so they have a more severe form of the disease. And since both alleles contribute to the phenotype, this is considered a co-dominant disorder. As the name implies, patients who have alpha-1 antitrypsin deficiency have decreased quantities or dysfunctional alpha-1 antitrypsin. What alpha-1 antitrypsin does is it's a protein that balances and counteracts the effects of elastase enzymes. And elastase is found naturally in neutrophils and alveolar macrophages. So when patients are deficient in alpha-1 antitrypsin, elastase is overactive, and that can lead to lung damage. The way you can think about emphysema in general and alpha-1 antitrypsin deficiency specifically is that there's always a balance in our lungs between enzymes called proteases, which break down protein structures, and antiproteases, which inhibit the proteases. So in smokers, the smoke causes inflammation and there's too many proteases created. This overwhelms the antiproteases and leads to lung damage, and typically the damage in smokers occurs in the upper lungs. In patients with alpha-1 antitrypsin deficiency, their problem is not an excess of proteases. Their problem is inactive amounts of alpha-1 antitrypsin, which is an antiprotease. So when these levels are low, that also leads to an excess activity of proteases. And this tends to cause lung damage as well, although in alpha-1 antitrypsin deficiency, it's usually in the lower lobes of the lung. So let's talk about the clinical features of alpha-1 antitrypsin deficiency. First of all, it can affect the lung and cause emphysema. There's an imbalance between neutrophil elastase, which we just talked about. This is an enzyme that destroys elastin, and the elastase inhibitor, alpha-1 antitrypsin, which is protective. This leads to lower lung damage like we just discussed. There are also problems in the liver among patients with alpha-1 antitrypsin deficiency, and they can develop cirrhosis. The abnormal form of alpha-1 antitrypsin can build up in the liver. This is only seen in patients who have a specific type of alpha-1 antitrypsin deficiency, where there is polymerization of the AAT molecules in the endoplasmic reticulum of hepatocytes. Those patients can develop liver damage and cirrhosis, but there are many patients who have severe alpha-1 antitrypsin deficiency but no problems in the liver, and that's because they don't have a form where the alpha-1 antitrypsin polymerizes in hepatocytes. To make the diagnosis of alpha-1 antitrypsin deficiency, you can measure a serum alpha-1 antitrypsin level. There's also genetic testing for some of the common mutations. The timing of manifestations of the disease varies. In the first 40 years of life, that's when the liver disease can present. So a young patient with unexplained liver disease could have alpha-1 antitrypsin deficiency. After age 40 is when the lung features present, and that's when patients can develop emphysema. A super high yield thing to note for your boards about this disorder is that these patients should never smoke. There's lots of evidence that many patients with this disorder, if they don't smoke, will never develop lung disease. What the lungs cannot tolerate is to be deficient in alpha-1 antitrypsin and have smoking on top of that. The treatment is the usual COPD care. In addition, there is an intravenous infusion of pooled human alpha-1 antitrypsin that is available. And so the classic case to note for your boards is a patient with typical COPD symptoms like cough, sputum, and wheezing. The patient will be younger, usually in their 40s. The onset of COPD from smoking at age under 45 is incredibly rare. So if a patient in their early 40s is described as having symptoms of COPD, they are most likely describing a case of alpha-1 antitrypsin deficiency. The patient may be a prior or current smoker, because remember that patients with alpha-1 antitrypsin deficiency who smoke are the ones that tend to get lung disease. Imaging will show emphysematous changes, most prominent at the bases, because that's where alpha-1 antitrypsin deficiency lung disease occurs. And then finally, if pulmonary function testing is done, it will show evidence of obstructive lung disease. And that concludes our module on COPD diagnosis.
Chronic bronchitis is quite variable. In some patients, cough and sputum. Restrictive lung diseases, and intro. Gas exchange frequently impaired rightward arrow downward arrow diffusion capacity. Predominant feature, inflammation and fibrosis of lung interstitium airflow usually preserved, no primary obstruction. Progressive disease leads to respiratory insufficiency. Often chronic and irreversible. 2 major categories. 1 intrinsic, pulmonary primary parenchymal diseases. 2 extrinsic, extrapulmonary chest wall or neuromuscular. 6. 1 intrinsic restrictive lung diseases. Primary involvement of lung parenchyma and interstitium etiology, often unknown or multifactorial. Dominant processes are inflammation and fibrosis. Interstitial thickening impairs gas diffusion. Lung becomes stiff rightward arrow upward arrow and work of breathing. Progressive scarring rightward arrow irreversible loss of function. End stage disease rightward arrow honeycomb lung. 7. 2 extrinsic restrictive lung diseases. AKA, extrapulmonary RLDs. Lungs normal restriction caused by impaired chest wall mechanics etiologies. A chest wall deformities rightward arrow kyphoscoliosis. B neuromuscular disorders rightward arrow reduced ventilatory effort. C. Severe obesity rightward arrow limited diaphragmatic excursion. D pleural diseases rightward arrow fibrous pleuritis, effusions. Pulmonary compliance preserved early. 8. Clinico-radiologic features of ILDs. Progressive exertional dyspnea is the earliest symptom. Tachypnea with shallow breathing pattern. End inspiratory fine crackles common. Wheezing typically absent. Chest imaging shows bilateral diffuse abnormalities. Reticular lines. Small nodules. Ground glass opacity. 9. Patterns. 10. Category diseases. I-fibrosing. Usual interstitial pneumonia, idiopathic pulmonary fibrosis, nonspecific interstitial pneumonia. Cryptogenic organizing pneumonia. Connective tissue disease, associated. Pneumoconiosis. Drug reactions. Radiation pneumonitis. 3 granulomatous. Sarcoidosis. Hypersensitivity pneumonitis. 3 eosinophilic lung diseases. 4. Smoking related. Desquamative interstitial pneumonia. Respiratory bronchiolitis, associated interstitial lung disease. 4 other. Langerhans cell histiocytosis pulmonary alveolar proteinosis lymphoid interstitial pneumonia. Major. Categories of intrinsic chronic interstitial lung diseases. Idiopathic pulmonary fibrosis, IPF. AKA, usual interstitial pneumonia, UIP. European term, cryptogenic fibrosing alveolitis. Chronic, progressive fibrosing interstitial lung disease. Defined as a clinico-pathologic syndrome, not a single lesion. Caused by progressive interstitial fibrosis and respiratory failure. Etiology, idiopathic. Disease course, irreversible and usually fatal. 11. 1. Fibrosing ILDs. Idiopathic pulmonary fibrosis, IPF. 12. IPF is a specific form of chronic fibrosing ILD of unknown cause. One of the most common and the most lethal ILDs. Caused by histologic and radiologic pattern of UIP. UIP is the morphologic pattern of IPF, histology plus HRCT. UIP pattern is nonspecific, also seen in CTD-associated ILD. Chronic hypersensitivity pneumonitis, others. Diagnosis of IPF, multidisciplinary, clinical, radiologic and histopathology correlation. Epidemiology. 13. First or second most common ILD, 17%, 86%, US incidence 93.7 per 100,000. Incidence upward arrow with age, common age 55 to 75 years. 50 years old, consider familial IPF and CT diseases. Sex, male predominance. Lower incidence and prevalence in Asia. Currently increasing globally. Pathogenesis. Complex and incompletely understood. Occurs in genetically predisposed individuals. Primary event, alveolar epithelial cell damage and senescence fibrosis, driven by disordered healing, not inflammation alone. 14. The key event. Repeated alveolar pneumocytes injury and aberrant repair by activated fibroblasts. Pathogenesis, environmental factors. Cigarette smoking, strongest environmental risk factor. Smoking increases IPF risk several-fold. Other implicated exposures, air pollution, microaspiration, metal, fumes, wood dust. High-risk occupations, farming, hairdressing, stone polishing. Recurrent epithelial injury is the common pathway. 15. 16. Pathogenesis, genetic factors. Most exposed guys do not develop IPF. Rightward arrow genetic susceptibility mutations affecting telomere maintenance. Upward arrow risk. TERT, TERC, PARN, or TEL1. Telomere dysfunction. Rightward arrow cellular senescence. 15% of familial IPF linked to inherited telomere defects. 25% of sporadic IPF shows telomere shortening in lymphocytes. 1/3 of IPF cases linked to MUC5B promoter polymorphism. Upward arrow MUC5B secretion. Rightward arrow altered mucociliary clearance. 17. Fibrogenic mechanisms. Injured epithelial cells release profibrotic mediators, example TGF-beta. Immune cells may amplify fibrogenic signaling. Fibroblasts show abnormal activation and persistence. 18. Collagen. 19. Environmental factors that are potentially injurious to alveolar epithelium interact with genetic or aging-related factors that place epithelium at risk, creating a persistent epithelial injury. Factors secreted from injured/activated epithelium, possibly augmented by factors released from innate and adaptive immune cells responding to danger signals produced by damaged epithelium, activate interstitial fibroblasts. There is some evidence that these activated fibroblasts exhibit signaling abnormalities that lead to increased signaling through the PI3K/AKT pathway. The activated fibroblasts synthesize and deposit collagen, leading to interstitial fibrosis and eventual respiratory failure. Proposed pathogenesis of IPF. 20. A normal lung B. In the early phase, patchy dense fibrosis involves peripheral and periveneal areas, but the architectural destruction is mild. Here, a fibroblastic focus is located between the fibrotic area and normal lung. C and D. In the later phase, structural remodeling due to wider fibrosis causes shrinkage, where that honeycomb cysts develop in association with traction bronchiectasis. Red lines, arteries, blue lines, veins, yellow lines, lymphatic ducts, and green areas, fibroblastic foci. Pathologic schema of UIP. AB. CD. Gross morphology. Pleural surfaces appear cobblestoned. Caused by retraction along interlobular septa. Cut surface shows firm, rubbery, white fibrotic areas. Honeycomb appearance in advanced stages. Fibrosis predominates in lower lobes, subpleural regions, and interlobular septa. 21. 22. A 78-year-old woman with idiopathic pulmonary fibrosis, IPF. Photograph of lungs obtained at autopsy. Performed 2 months after. Cobblestone appearance. 23. A 78-year-old woman with idiopathic pulmonary fibrosis, IPF. Photograph of coronal cut surface of resected lungs shows honeycomb lungs, closely resembling CT appearance. Honeycomb appearance. Microscopic morphology. Patchy interstitial fibrosis with variable intensity. 1 early lesions, show fibroblastic foci, FF. 2 older areas, dense, collagenous, and hypocellular. Diagnostic feature, temporal heterogeneity. Destruction of alveolar architecture. Formation of cystic air spaces, honeycomb lung. Cysts lined by, hyperplastic T2 pneumocytes or bronchiolar epithelium. 24. Subpleural fibrosis. 25. 26. Dense fibrosis with architectural destruction. Honeycomb change. 27. Fibroblast focus. Fibroblast focus. Fibroblast focus. Fibroblast focus. Clinical features and course. Insidious onset of progressive exertional dyspnea. Persistent dry cough, no wheezing, non-obstructive disease, late findings, hypoxemia, cyanosis, digital clubbing. Course is variable and unpredictable. The median survival 3.8 years after diagnosis. Most slowly progress to respiratory failure. Some rightward arrow rapid decline with acute exacerbations. End-stage disease equals honeycomb lung plus COR pulmonal. 28. Treatment. Lung transplantation, the only definitive therapy. 2 disease-modifying drugs approved. 1 tyrosine kinase inhibitor. 2. TGF-beta pathway antagonist. Therapy slow progression, not curative. Represent first targeted treatments for IPF. 29. Nonspecific interstitial pneumonia. NSIP, chronic ILD with uniform inflammation plus or minus fibrosis. Named nonspecific historically, but distinct entity with prognostic value. Second most common interstitial pneumonia, after IPF, prognosis significantly better than UIP/IPF. Often associated with connective tissue disease, CTD, can be idiopathic when no cause identified. 30. 2. Fibrosing ILDs. Etiology and associations. NSIP pattern seen in connective tissue diseases, most common, example scleroderma. Hypersensitivity pneumonitis drug-induced lung injury. Infections. Idiopathic NSIP often represents early or incomplete autoimmune disease. Diagnosis requires clinical, radiologic, pathologic correlation. 31. Morphology, 2 histologic patterns. Diffuse and uniform inflammation of alveolar wall and pleura. Called temporal homogeneity. There are usually no normal alveolar walls in the affected lobules. Can be cellular or fibrotic or both. Findings of interstitial pneumonia with autoimmune features. Lymphoid aggregates with germinal center. Prominent plasmacytic infiltration. Dense perivascular collagen, and extensive pleuritis. 32. Morphology, 2 histologic patterns. Cellular NSIP, mild, moderate chronic interstitial inflammation. Lymphocytes plus or minus plasma cells and fibrosis is minimal fibrosing NSIP, diffuse or patchy fibrosis of similar age. Loose, uniform fibrosis. Lung architecture often preserved. Both patterns can coexist together. Temporal heterogeneity, early plus late lesions, screams rightward arrow UIP/IPF. 33. Epidemiology and distribution. Mean age, 50 to 60 years. Sex, female predominance. No strong smoking association. Location, B basilar, lower lobe predominant. Often bilateral and symmetric. Idiopathic NSIP is less common than secondary NSIP. 34. Lymphocytic infiltration and fibrosis. Lymphoplasmacytic infiltration. Uniform involvement. 35. AB. CD. Treatment and prognosis. Many patients improve or stabilize with glucocorticoids plus or minus immunosuppressants. Treat underlying cause when present. Much better prognosis than UIP/IPF. 5-year survival overall 70%. IPF contrast, steroids ineffective, antifibrotics required. Median survival 3-5 years. 36. 37. Feature NSIP, nonspecific interstitial pneumonia. UIP/IPF, usual interstitial pneumonia. Core nature inflammatory plus or minus fibrosing ILD with minimal inflammation typical cause often secondary idiopathic by definition, IPF. Sex female male. Smoking association weak/absent strong. Distribution bilateral, B basilar, symmetric, diffuse, subpleural, basal, patchy. Temporal pattern temporal homogeneity, same stage lesions, temporal heterogeneity, early plus late lesions, inflammation mild, moderate, prominent minimal. Fibrosis uniform, loose dense, destructive. Fibroblastic foci absent present, hallmark. Honeycombing absent or minimal prominent. Lung architecture largely preserved severely distorted. HRCT pattern ground glass, reticular opacities reticulation plus honeycombing response to steroids good/moderate poor. Prognosis much better poor. 5-year survival 60, 70% 20, 30%. Transplant needed rare often. Cryptogenic organizing pneumonia. Organizing pneumonia equals repair response to lung injury intraalveolar process, not primary interstitial fibrosis. Characterized by polypoid plugs of loose connective tissue. Note, underlying lung architecture is preserved. COP equals idiopathic form of organizing pneumonia. Diagnosis made by multidisciplinary exclusion, not histology alone. 38. Fibrosing 3. ILDs. Etiology and terminology. Secondary organizing pneumonia, most common type, 6.5:1. Etiologies include infection, viral, bacterial, fungal, lung abscess, emphysema drugs, inhaled toxins. Connective tissue diseases, RA, Sjogren syndrome. GVHD, radiation, aspiration. Cryptogenic organizing pneumonia, COP no identifiable. Cause and it's rare. 39. Pathogenesis. Lung injury rightward arrow endothelial and epithelial damage. Plasma proteins leak rightward arrow fibrin deposition in alveoli fibroblasts migrate and proliferate. Formation of loose granulation tissue plugs. Cytokines involved, IL-6, IL-8, TGF-beta. Organizing pneumonia represents aberrant but potentially reversible healing. 40. Morphology, hallmark features. Mass in bodies, polypoid fibroblastic plugs. Located in alveoli, alveolar ducts, bronchioles. Alveolar architecture is usually preserved in COP. Connective tissue is uniform in age. No dense interstitial fibrosis, or architectural destruction. Interstitial inflammation is only minimal. 41. Fibroblast plug. Fibroblast plug. Fibroblast plug. Mass in bodies fibroblast plug. 42. 43. Fibroblast plug. Lung, organizing pneumonia, typical low magnification appearance of a nodular area of consolidation centered on a bronchovascular bundle. Mass in bodies. 44. Fibroblast plug. Lung, organizing pneumonia, several air spaces are completely occluded by fibroblast plugs. The alveolar walls are expanded by inflammatory. Infiltrate. Mass in bodies. Clinical features and prognosis. Subacute onset, weeks, months. Dry cough, dyspnea, low-grade fever, malaise, fatigue, crackles on auscultation. Mild restrictive pattern or near normal PFTs. Often misdiagnosed as non-resolving pneumonia. Excellent prognosis compared with IPF. Many recover spontaneously. Most respond dramatically to oral corticosteroids. 45. 46. Feature COP IPF. Primary process intraalveolar. Weave fibroblastic plugs. Interstitial fibrosis, weave fibroblastic foci. Architecture preserved destroyed. Fibrosis loose, reversible dense, irreversible. Honeycombing absent present. Age of lesions uniform temporal heterogeneity steroid response excellent poor. Prognosis good poor, median 3.8 YRS. COP, cryptogenic organizing pneumonia. IPF, idiopathic pulmonary fibrosis. Feature COPD ILDs, restrictive lung diseases. Primary problem airflow obstruction reduced lung expansion. Pathologic compartment airways and alveoli alveolar septa.
Emphysema. What is emphysema? The irreversible enlargement of respiratory style. Nasıl kolay?
Hi, everybody, and welcome to our module on restrictive lung disease. Restrictive lung diseases are lung disorders where there's some restriction to expansion of the lungs. And welcome to our module on restrictive lung disease. Restrictive lung diseases are lung disorders where there's some restriction to expansion of the lungs, and therefore air cannot get in normally unless air goes out. The main symptoms of all the restrictive lung diseases are dyspnea. This is usually the dominant clinical feature. And because of dyspnea, patients are often referred for spirometry, and they will have findings consistent with restrictive physiology. In another video, I talk about pulmonary function testing in detail, but here I'll just briefly review the findings of restrictive lung disease on spirometry and pulmonary function testing. So in this graph on the screen, this is the results of a spirometry test. Time is along the x-axis, and the volume exhaled is along the y-axis. The red line is what normal lungs look like by spirometry. The blue line is what patients with obstructive lung disease like COPD look like by spirometry. And the yellow line here is what patients with restrictive diseases look like. So these patients have a reduced FEV1 compared to normal. This is the normal FEV1 up here, and these patients are down here. They also have a reduced forced vital capacity, or FVC. The normal FVC is here, and these patients are down here. Importantly, however, the ratio of FEV1 to FVC is normal, meaning greater than 80%, and this is what distinguishes restrictive lung disease from obstructive disease. Patients with obstructive disease also have a reduced FEV1 and a reduced FVC, but the FEV1 is reduced more so that the ratio of FEV1 to FVC falls. It does not fall in restrictive lung diseases, it stays normal or even sometimes can increase. And then finally, the total lung capacity is reduced in restrictive lung diseases. As you can imagine, if there's some restriction preventing the lungs from expanding, the total lung capacity is going to decrease. In the video on pulmonary function tests, I also talk about flow volume loops in detail, but here I'll just briefly review that the normal flow volume loop looks like this section. But of these disorders here, only interstitial lung disease causing oxygenated blood coming through the alveoli gets AA gradient is about 10 to 15. Before I told you that disease, which we're going to talk about later, specific causes of restrictive lung disease. And that's often a board question. The treatment is not bronchodilatation or pulmonale, which is a lung biopsy. Lung biopsy is important because this helps you. The number of autoimmune disease clinically is idiopathic pulmonary fibrosis, usually called IPF. This disorder prevents the capacity of basically the overall percent. And this is what line is what patients with obstructive lung disease like COPD look like by spirometry. And the yellow line here is what patients with restrictive diseases look like. So these patients have a reduced FEV1 compared to normal. This is the normal FEV1 up here, and these patients are down here. They also have a reduced forced vital capacity, or FVC. The normal FVC is here, and these patients are down here. Importantly, however, the ratio of FEV1 to FVC is normal, meaning greater than 80%, and this is what distinguishes restrictive lung disease from obstructive disease. Patients with obstructive disease also have a reduced FEV1 up here. And
Wait a minute. Videoyu kalla sunnalı malın. Let us video to nail. Let us order this. እሺ ስንት ደቂቃ ነው? 6 18 እሺ now restrictive okay so now 21 ደቂቃ ነው ረጋ ብዬ ይሄን ልይ so let's close this ስቶሬጁን እንትን ለማድረግ ለመቆጠብ let's close let's delete here this now
These patients are down here. They also have a reduced forced vital capacity, or FV. Hi, everybody, and welcome to our module on restrictive lung disease. Restrictive lung diseases are lung disorders where there's some restriction to expansion of the lungs, and therefore air cannot get in normally unless air goes out. The main symptoms of all the restrictive lung diseases are dyspnea. This is usually the dominant clinical feature. And because of dyspnea, patients are often referred for spirometry, and they will have findings consistent with restrictive physiology. In another video, I talk about pulmonary function testing in detail, but here I'll just briefly review the findings of restrictive lung disease on spirometry and pulmonary function testing. So in this graph on the screen, this is the results of a spirometry test. Time is along the x-axis and the volume. exhaled is along the y-axis. The red line is what normal lungs look like by spirometry. The blue line is what patients with obstructive lung disease like COPD look like by spirometry. And the yellow line here is what patients with restrictive diseases look like. So these patients have a reduced FEV1 compared to normal. This is the normal FEV1 up here, and these patients are down here. They also have a reduced forced vital capacity, or FVC. The normal FVC is here, and these patients are down here. Importantly, however, the ratio of FEV1 to FVC is normal, meaning greater than 80%, and this is what distinguishes restrictive lung disease from obstructive disease. Patients with obstructive disease also have a reduced FEV1 and a reduced FVC, but the FEV1 is reduced more so that the ratio of FEV1 to FVC falls. It does not fall in restrictive lung diseases, it stays normal or even sometimes can increase. And then finally, the total lung capacity is reduced in restrictive lung diseases. As you can imagine, if there's some restriction preventing the lungs from expanding, the total lung capacity is going to decrease. In the video on pulmonary function tests, I also talk about flow volume loops in detail, but here I'll just briefly review that the normal flow volume loop looks like this one on the left side of the screen. Patients who have restriction have a shape of the flow volume loop as shown here. Basically, the overall loop becomes narrower, and these patients do not develop this deep scallop that you see with obstructive lung disease. So patients are said to have restrictive lung physiology if they have the spirometry findings we talked about 2 slides ago. Their FEV1 is down, their forced vital capacity is down, but the ratio of FEV1 to FVC is normal or increased. Once you know that patients have that physiology, there are 2 potential underlying mechanisms by which that physiology can occur. The first one is poor breathing mechanics. Patients with poor breathing mechanics have restrictive lung physiology, but their lungs are actually completely healthy. These patients have abnormalities of the chest wall or the nerves that innervate the muscles of respiratory function, and that is causing them to have a restriction in inflating the lungs. The second reason patients can have restrictive lung physiology is if they have interstitial lung diseases. We'll talk in detail about the interstitial lung diseases later. They're a group of disorders, but they all involve fibrosis and other abnormalities of the lungs that prevent the lungs from expanding normally. So the bottom line here is that these patients have completely healthy lungs, but they have a problem with the chest wall and the muscles of respiration. These patients have sick lungs, and that's what's causing the restrictive physiology. So once you have a patient with dyspnea and restrictive physiology by PFTs, how are you going to determine whether the cause of that restrictive physiology is poor breathing mechanics or interstitial lung diseases? Well, one way you can do this is by measurement of the diffusing capacity of lung carbon monoxide, otherwise known as the DLCO. I discussed this test in detail in the video on pulmonary function testing, but by way of review, this is a test of the ability of the lungs to uptake gas. It's done using carbon monoxide, that's why it's called the DLCO. And it can be used to separate cases of restrictive lung disease into those that are due to poor breathing mechanics and those that are due to interstitial lung disease. Using the DLCO test, you can measure the ability of the lungs to transfer gas to RBCs. A normal result is anywhere from 75 to 140% are predicted, and patients with severe forms of lung disease can have a decreased DLCO as low as under 40%. So if a patient has restrictive physiology but their DLCO is normal, that tells you that the patient's lungs are healthy. These patients have poor breathing mechanics. They have some extrapulmonary cause of restriction. This could be obesity. This could be neuromuscular weakness. If patients have restrictive physiology but the DLCO is low, this tells you that the lungs are not healthy. And these are the findings that you see in patients who have interstitial lung disease. Shown on this slide are lung conditions associated with a low DLCO measurement. And at the top of the list is interstitial lung disease. We'll talk about this later, but this is a common cause of restrictive lung physiology, and it's associated with a low DLCO. Other lung conditions that can cause a low DLCO include emphysema, problems with the pulmonary vasculature like pulmonary hypertension and pulmonary embolism, and patients who have had a prior lung resection. But of these disorders here, only interstitial lung disease causes restrictive physiology, and for this reason, the DLCO can be very helpful in categorizing patients who have restrictive lung disease. So let's look at this flowchart on the screen here. Imagine you have a patient with dyspnea or hypoxemia, and you refer them for spirometry, and the results indicate restriction. Those results would be a low FEV1, a low FVC, but a normal FEV1 to FVC ratio. Once you get these results, you know the patient has restrictive lung disease, but you don't know the cause. So the next step you can do is to measure the DLCO. If the DLCO is normal, this means the patient has healthy lungs, and the cause of the restriction must be something to do with the chest wall or some neuromuscular disorder. On the other hand, if the DLCO is low, this means the patient has lung disease, and that patient is therefore going to have interstitial lung disease because this is the only cause of lung disease associated with restrictive physiology. So back to the slide, in patients with restrictive physiology, one way you can determine whether their problem is poor breathing mechanics or interstitial lung disease is by using the DLCO test. The other way you can do this is by measuring the AA gradient, so let's talk about that now. So in order to understand the AA gradient, I've made a drawing here of an alveolus with a pulmonary capillary and blood is flowing past the alveolus like this. In a person breathing normal room air, the partial pressure of oxygen in the inspired air is 150 millimeters of mercury. In the alveolus, however, the partial pressure is lower. It's usually about 100. That's because oxygen is taken up by the pulmonary capillaries, and also carbon dioxide is added to the gas in the alveolus. Now, blood that is entering the pulmonary capillary from the venous system has a very low partial pressure of oxygen. Usually it's about 40 millimeters of mercury or so, and the oxygen saturation is only about 70%. That's because this is venous blood and lots of oxygen has been removed by the body. After this blood goes through the pulmonary capillary, it travels to the arteries, and we can take a sample of blood from an artery and measure the oxygen concentration in that arterial blood. And if we do that, a normal level of oxygen in the arterial blood is about 90, and usually the blood is 100% saturated with oxygen. So if you understand these numbers, then hopefully you can see that the oxygen content of the alveoli is 100, but the oxygen content of the arterial blood is lower at 90. So why is that the case? The reason that's the case is because there is some venous blood that does not go through the lungs. There are small channels that allow venous blood to get to the arterial system without being oxygenated. So some of this oxygenated blood coming through the alveoli gets mixed with venous blood that has a low oxygen content, and the result is arterial blood that has a lower oxygen content than the alveoli. And this difference between the 100 millimeters of partial pressure of oxygen in the alveoli and the 90 in the arterial is called the AA gradient, and a normal AA gradient is about 10 or so, just like shown in this example here. Now, in clinical practice, if you want to determine the AA gradient for a patient, it's easy to get the PaO2 of the arterial blood. You simply do an arterial blood gas. But how are you going to get the concentration of oxygen in the alveoli? We don't have a way to sample gas from the alveoli. So in order to get this number, you're going to have to use the alveolar gas equation. So this is the alveolar gas equation, and it says that the P big AO2, which is the concentration of oxygen in the alveoli, is equal to the partial pressure of oxygen in the inspired air minus the partial pressure of carbon dioxide in the arteries divided by a constant R, which is equal to 0.8. So we can use this equation to determine the P big AO2 if we know how much oxygen the patient is breathing in, and we usually know that, and if we measure the CO2 concentration in an arterial blood gas sample, which is also easy to do. So using this equation, we can get the concentration of oxygen in the alveoli and determine the AA gradient. So here's a summary of everything we've just talked about. The AA gradient is the difference between the alveolar and the arterial oxygen content, and it's helpful for evaluating hypoxemia. Step 1 in determining the AA gradient for your patient is to measure the P little AO2 and the P little A CO2. These are the concentrations of oxygen and carbon dioxide in the arteries, and they come from an arterial blood gas test. Step 2 is to determine the P big AO2 from the alveolar gas equation, and once you have that number, the AA gradient is the P big AO2 minus the P little AO2. And a normal AA gradient is about 10 to 15 millimeters of mercury, and as I said before, this happens because of shunting. Some venous blood does not go through the lungs and pick up oxygen. Specifically, some venous blood goes through the sebacean and bronchial veins and drains directly into the left side of the heart without picking up oxygen, and that's what causes the normal AA gradient. So the reason the AA gradient is important is because it helps you classify causes of hypoxemia and potentially determine the underlying etiology. So if a patient has hypoxemia but their AA gradient is normal, this tells you their lungs are healthy and their lungs are taking up oxygen normally. The problem these patients have is that they're not taking in enough oxygen into the lungs, and there are two reasons this can occur. The first is if they're breathing air with a low oxygen content. This is what happens at high altitude. So before I told you that a normal PiO2 for someone breathing room air is 150 millimeters of mercury, and this is what occurs at sea level. But if you go up to very high altitude, the PiO2 can get as low as 100 or even lower in some cases, and when this happens, that's going to decrease the amount of oxygen in the alveoli, and therefore it's going to cause hypoxemia. But the AA gradient will stay normal because the lungs are taking up gas normally. The other way you can get hypoxemia with a normal AA gradient is if the patient is hypoventilating. So if the patient has a low respiratory rate or a low tidal volume for any reason, that patient will develop hypoxemia, but they will have a normal AA gradient because the lungs are taking up oxygen normally. And this is what happens with patients who are over-medicated by narcotics and are hypoventilating for that reason. It also happens to patients with forms of neuromuscular weakness and also patients who are very obese. In contrast, patients who have hypoxemia but a high AA gradient have some problem with their lungs. Remember, a normal AA gradient is 10 to 15, so if you have a patient with dyspnea and hypoxemia and you measure the AA gradient and it's 100, then that patient has some problem with the lungs. There are many lung diseases that can cause hypoxemia with a high AA gradient. I've just listed a few of them here, but one of them is interstitial lung disease, which we're going to talk about later, and it causes restrictive lung physiology. Other lung diseases include pneumonia, COPD, and many others. These can all cause hypoxemia, and the AA gradient will be high. So back to our discussion of restrictive lung disease, let's talk about how we can use the AA gradient to classify patients with restrictive lung physiology. So if you have a patient with dyspnea or hypoxemia and their spirometry shows evidence of restriction, meaning a low FEV1, a low FVC, but a normal FEV1 to FVC ratio, you can then use the AA gradient to classify these patients. If the AA gradient is normal, remember that tells you the patient has healthy lungs. So these patients have some problem with the chest wall or some neuromuscular disorder. On the other hand, if the AA gradient is high, then that patient has some problem leading to sick lungs. And this always means interstitial lung disease when you're talking about restriction. Of the causes of a high AA gradient, only interstitial lung diseases are associated with restrictive spirometry. So now that we've talked about restrictive physiology and the diagnosis and workup of restrictive lung diseases, I'm going to finish this video by talking about some specific causes of restrictive lung disease. And the first one I'll talk about is the obesity hypoventilation syndrome. This is very, very common. You'll see it among many obese patients that you treat in the hospital. It's a common cause of dyspnea. These patients have a restrictive pattern on pulmonary function testing. Their lungs are healthy. The problem is that their chest wall is overburdened by all the fat tissue, and therefore they cannot inhale normally, and they present with restrictive physiology. But because their lungs are healthy, their AA gradient is normal, and so is their DLCO. If you do a blood gas on these patients, they almost always have hypercapnia, meaning an increased level of carbon dioxide. And the reason they have that is because they are hypoventilating. These patients cannot expand the lungs normally because of the restriction around their lungs due to fatty tissue, and therefore they hypoventilate and the CO2 level gets high. The chronically high CO2 level leads to compensation by the kidneys, so these patients also often have an increased bicarbonate. This is very similar to the way patients with COPD can present. They also tend to have hypercapnia and a high bicarbonate from chronic hypoventilation. And the treatment is weight loss, so this is often a board question. The treatment is not bronchodilators or lung surgery, it's usually weight loss. Moving on, let's talk about the interstitial lung diseases. Interstitial lung diseases are a large group of disorders. They're sometimes called diffuse parenchymal lung diseases, and they get this name because what's happening in these disorders is that there's some type of inflammatory problem involving the alveolar wall. This leads to the laying down of fibrosis, and once there's fibrous tissue present in the alveoli cannot distend normally, and this leads to restriction and restrictive physiology. As we will see in the next few slides, there are many, many causes of interstitial lung disease, but they all share similar clinical, radiographic, physiologic, and pathologic manifestations. Basically, all these patients present in a relatively similar way with similar clinical findings. In particular, all of them have restrictive pulmonary function testing results. They all have a low DLCO and an increased AA gradient, and the reason they have a low DLCO and an increased AA gradient is because these are lung diseases involving the lung itself, and as I mentioned before, low DLCO and high AA gradients are associated with lung problems themselves, not extrapulmonary problems like problems of the chest wall. As I said before, the many causes of interstitial lung disease all share some common clinical presentation features. In particular, they all tend to present with dyspnea and a non-productive cough. There are often diffuse crackles on lung exam because of the fibrous tissue generally affecting all the areas of the lungs. A classic finding is the presence of Velcro-like rails at the lung bases. Some forms of interstitial lung disease can lead to clubbing of the fingers. We'll talk about this in a minute, but in particular, idiopathic pulmonary fibrosis often has clubbing associated with it. And then finally, all these disorders can cause chronic lung disease, and that can lead to cor pulmonale, which is a special form of right heart failure caused by lung problems. The chest X-ray in patients with interstitial lung disease usually has non-specific findings. The classic finding in interstitial lung disease, which is uncommon, is the presence of diffuse honeycombing, as shown in the slide here. This is a bilateral diffuse pattern of lung findings. There tend to be these small irregular opacities. You can see these white lines here. These are sometimes referred to as reticulonodular, which is just a way of describing the irregularity of these opacities. And as I said before, it's often described as a honeycomb lung appearance. In a patient with dyspnea and cough, the best first test is a chest X-ray, but once you get a chest X-ray, if you suspect interstitial lung disease, the best next test is a chest CT. This is a chest CT from a patient of mine with interstitial lung disease. You can see these diffuse white streaky patterns. It looks like a honeycomb pattern. This is a classic finding in interstitial lung disease. For a definitive diagnosis, you need to do a lung biopsy. A lung biopsy is important because this helps you differentiate between the multiple causes of interstitial lung disease. So as I mentioned before, the interstitial lung diseases are a group of disorders, and there are many different causes of interstitial lung disease. And on this slide, I've listed some of the important causes of interstitial lung disease. First are the environmental exposures. We'll talk a little bit more about this in a few slides, but there are a number of disorders that are caused by things in the environment. Usually workers are exposed to them, and these lead to interstitial lung disease. And this includes coal workers' pneumoconiosis, silicosis, asbestosis, and borreliosis. Some granulomatous diseases like sarcoid and forms of vasculitis can cause interstitial lung disease, and good pastures, which is an autoimmune disease involving the alveoli, can also lead to interstitial lung disease. A number of drugs are associated with interstitial lung disease. Some of the classic agents are amiodarone, bleomycin, and methotrexate. A number of autoimmune diseases are associated with interstitial lung disease. This includes rheumatoid arthritis, lupus, and scleroderma. And then finally, there are other causes. One of them is idiopathic pulmonary fibrosis, which we'll talk about in a minute. Another is cryptogenic organizing pneumonia. And then finally, patients who are exposed to radiation to the chest can develop radiation pneumonitis, and this can lead to interstitial lung disease. So this is a long list, and it's fairly low yield to memorize all the causes of interstitial lung disease. But what you do want to know is that in any patient with a new diagnosis of interstitial lung disease, you want to take a medication history, an occupational history, and you want to identify key elements of the past medical history. In terms of medicines, you want to know if they're exposed to any drugs like this. In terms of occupation, you want to know if they were exposed to things that can cause lung disease. And in terms of past medical history, you want to know if they have any of these conditions that could lead to interstitial lung disease. One of the more common causes of interstitial lung disease that you'll see clinically is idiopathic pulmonary fibrosis, usually called IPF. This disorder presents with slow onset dyspnea and non-productive cough, and the term slow onset is important. It usually takes months or even years for this disorder to be diagnosed because it is so gradual. It typically affects older patients, usually in their 60s or 70s, and it's a progressive disease. The mean survival from the time of diagnosis is about 3 to 7 years. Most of these patients end up on oxygen and ultimately succumb to lung disease. It's classically associated with digital clubbing, and this is a picture of digital clubbing on the slide here to remind you of that. The diagnosis, like we talked about earlier, is made with chest CT, showing findings like this on the screen here, plus biopsy. The mainstay of treatment is simply supportive care, usually by giving oxygen. In some cases, lung transplantation is a possibility. And very recently, 2 new agents have come on the market that can inhibit fibroblast activity and slow the progression of development of fibrous tissue in the lungs. These 2 agents are called pirfenidone and nintedanib, and these are potentially options for some patients. Another cause of interstitial lung disease is called cryptogenic organizing pneumonia, or COP. In this disorder, granulation tissue deposits in the alveolar walls, and this prevents the alveoli from expanding, and that leads to restrictive lung physiology. These patients present with symptoms very similar to pneumonia, symptoms like cough, dyspnea, and malaise. Usually they develop over weeks or months. The classic finding on chest X-ray is the presence of bilateral patchy infiltrates. This is an example shown on the screen here. You can see these patchy white infiltrates here. Here's some more here. There's some over here. And both sides of the lungs, therefore bilateral. Now, because this disorder looks like pneumonia, most patients are treated with antibiotics, but when they don't get better, that lack of response to antibiotics is what ultimately suggests a diagnosis. The diagnosis can be made by lung biopsy, and the treatment is with corticosteroids. A pneumoconiosis is an occupational lung disease, and there are a number of different pneumoconiosis disorders. Some of them are listed on this slide here. These include coal miner's lung, silicosis, asbestosis, and borreliosis. And with all of these disorders, the idea is that workers are exposed to certain environmental contaminants as part of their job, and these contaminants lead to inflammation and fibrosis in the lungs. The mainstay of treatment is to avoid additional exposure, and most of these have no specific treatment other than avoiding additional exposure so there isn't further lung damage. I'll talk about just one of the pneumoconiosis disorders, and that's asbestosis. This occurs in workers who inhale asbestos fibers, and asbestos fibers are important in the shipbuilding industry, also in roofing and plumbing. It causes dyspnea and other typical symptoms of interstitial lung disease. It often causes clubbing of the fingers. The classic chest X-ray finding in a patient with asbestosis is the presence of pleural plaques. These are not easy to identify in a chest X-ray if you're not a radiologist, but there is one shown here in this image. It's right here at the tip of this black arrow. And in addition to causing asbestosis, which is a form of interstitial lung disease, asbestos exposure is also associated with lung cancer. Patients exposed to asbestos can get bronchogenic carcinoma, They're also at risk for a rare pleural tumor called mesothelioma. And I'll finish this video by discussing hypersensitivity pneumonitis. As the name implies, this is a lung disorder that involves a hypersensitivity reaction to some environmental antigen. One of the classic examples of hypersensitivity pneumonitis is called farmer's lungs. When farmers are exposed to moldy hay or grain, they can develop a hypersensitivity reaction in the lungs. And I've put a picture of a farmer here on the screen to remind you of that. Hypersensitivity pneumonitis is also common in people who handle birds or poultry. The waste from those animals can become dried and become finely dispersed as dust, and it can be inhaled, and that can cause a hypersensitivity reaction. So the classic case of this disorder to note for your boards is a farmer or a bird handler who develops cough and dyspnea and diffuse crackles and bilateral interstitial infiltrates, just like you would expect for a patient with interstitial lung disease. This is a picture on the screen here of someone who has hypersensitivity pneumonitis. Note the diffuse bilateral infiltrates. And the treatment is to avoid exposure and also corticosteroids. And that concludes our module on restrictive lung disease.